Hey guys, this is CT 4071. We're in lesson 3, part 2 of hepatobiliary, which kind of includes some other organs. So today we're going to be talking about the spleen, the pancreas, and the adrenal glands. Shouldn't take too long. The spleen is evaluated concurrently with the other organs of the abdomen on CT exams, and it's optimally imaged after IV contrast administration. The unenhanced spleen is around 40 to 60 Hounsfield units, which is 10 Hounsfield units less than the liver. In the arterial phase, the spleen is heterogeneous, which means when you look at it, there's different levels of enhancement, and we'll talk about that when we look at the images in a second. So the preferred timing is portal venous phase at 60 to 70 seconds, which gives a more homogeneous enhancement and look to the spleen. Some indications for scanning the spleen include trauma, which is the most commonly due to blunt trauma to the abdomen, which can result in a hematoma, hemorrhage, or laceration. And also, we look for focal lesions such as benign cysts or hemangiomas, or malignant lesions like those that are from lymphomas or Mets. Another indication that's common in the spleen is a splenomegaly. There's enlargement of the spleens due to numerous etiologies such as lymphoma, portal hypertension, and infection. Another thing that you may see, saw one recently, is an accessory spleen. It's called a splenule. These appear as little small nodules of splenic tissue that are adjacent to the main spleen, and they can be mistaken for other types of masses. But your clue is that they enhance like the spleen, and they're adjacent to the spleen, and they're just circular nodules. But you may see those too. So looking at this in slide 87 here, this is how the spleen enhances the nice homogeneous appearance here of the spleen. This is a late phase where contrast is in the venous phase, 60 to 70 seconds. You can tell that because the liver is enhanced as well. And the vessels, the arteries, are not as bright as they would be in an arterial phase. So these 4 images here show excuse me, enhancement of the spleen. This is normal enhancement, and non-contrast enhancement. It's a normal spleen. And then B, this is arterial phase, and this is what I mean by the heterogeneous appearance. You can see it's kind of, only way to describe it is kind of mottled, and M-O-T-T-L-E-D. The enhancement is heterogeneous. There's different densities all around it, and it kind of looks like a diseased spleen when you first look at it if you don't know what the spleen does during enhancement. So it's best imaged on the late phase, which is C here, where it's nice and enhanced, but it's not mottled. It's a homogeneous appearance. And then, of course, this is a really late phase. There's a little difference between non-contrast and as it washes out of the spleen here. But your clue to this arterial phase is the aorta. See how brightly enhanced it is? Then you know you're on arterial phase. And here is a late phase where it's all washed out of the aorta. And you would see the aorta right here on this phase would be about what it looks like here. A little enhanced, but not nearly as bright as it is in arterial. So these are normal phases of the spleen, and it's the only organ that really does that. The liver, you'll see vessels before you see parenchyma, but with the spleen, the parenchyma just kind of highlights mottled appearance in the early arterial. So it's best to image the spleen if that's your specific organ of choice that they're requesting, which it's going to be included in the scan anyway. Late phase is best. Okay, let's talk about the pancreas now. The pancreas, CT imaging is the method of choice for evaluating the pancreas. for most indications, and it provides more reliable overall data than ultrasound and plain films, and contrast enhancement of the GI tract as well. So a technique that includes the use of thin slices and IV contrast improves the likelihood of visualizing the main pancreatic duct. In a jaundice patient, non-contrast scans through that area of the common bile duct might allow you to visualize common bile duct stones or calculi. Water or a low attenuation oral contrast is preferred because dense contrast can obscure those small stones. So if that's what you're looking for, you want to choose a low attenuation oral contrast. And when initial scans fail to differentiate the margins of the pancreas from the duodenum, patients often given an additional oral contrast material, and additional slices are obtained with the patient lying on the right decubitus position. This will cause the duodenum to drop and separate from the pancreas. And also, a lot of times, if you have dosed this patient and you've been waiting for a couple of hours and you scan them, all the contrast is out, and there's a question, you can give them a little bit more. And normally we do anyway right before we scan them, but if the pancreas and pancreatic duct are known, then you want to use the low attenuation oral water before you scan them. But if this is just a routine abdomen, normally you'll give them a little dose before you scan them. It's been 2 hours, so it's probably washed out of the area, the duodenum and all of that. So, multiphasic protocols are common for pancreatic indications. Most commonly, data acquisition is timed to coincide with the late arterial phase of pancreas, which is about 35 to 40 seconds after the injection, and then portal venous phase also about 60 to 70 seconds after injection. Because the exact timing of these phases is patient dependent, a lot of times you need to use the bolus tracking software. So looking at slide 88 here, the role of the CT in pancreas scanning is for pancreatic and peripancreatic inflammation and necrosis. The indications include neoplasms, which can be adenocarcinomas, which is the most common, cysts, endocrine masses such as islet cell tumors, trauma, and complications from cystic fibrosis, which is mainly a liver disease, but it can impair the pancreas's ability to produce insulin. Surgical removal of pancreatic tumors depends on vascular involvement and the local spread or the mets. And then a resection of the pancreas in the duodenum is called a Whipple procedure. You may hear that. You may scan patients after or before that as well. So, protocol for scanning the pancreas, we're going to do the non-contrast scan to localize it and identify any calculi in the ducts. And then we're going to give the oral contrast, which, like we said, is going to be water or a low attenuation, like a volumen or something like that. But it's going to distend the GI tract without the streaking artifact that you get when you give Gastroview with water, or you give normal barium and it concentrates in the stomach. It kind of streaks through the area that we're looking for. The IV contrast is 100 to 150 milliliters at 3 to 5 milliliters per second, because you want to catch the arterial phase at 20 to 25 seconds and then do a delayed pancreatic phase of 35 to 45 seconds, which is the pancreatic arterial phase, and then venous phase at 60 to 70 seconds. So here is some normal pancreatic anatomy. You see the pancreas is nice and outlined here, and there's the splenic vein coming in. I know it's bright, but it's coming from the IVC, so you see it's a splenic vein. And the superior mesenteric vein. That's where that's coming from. It's pretty big. You have gallbladder, liver here, kidney here, and the left adrenal's coming in, and then the spleen. But this is the pancreas laid out here really nicely. And here is pancreatitis. And this is advanced. There's this pancreatic necrosis going on here. There's all these air bubbles in here that's indicative of some necrotic tissue that's happening. This is the border of it, and here's some more necrosis going on. All the way down into this interstitium round is inflamed, and you have mesenteric stranding, which is where you're in the mesentery is inflamed and fluid is filling it, and so you're seeing the inflammation in the mesentery as well. This patient's going to be really, really sick. All right, let's talk about the adrenal glands. The CT's become a modality of choice in detection and characterization of adrenal masses, and this can be traced to two developments in CT. First, because CT is so frequently used in the diagnosis of abdominal symptoms and disorder, it often uncovers unsuspected adrenal masses, and those have often, as a result of unrelated symptoms, and the adrenal masses are found incidentally. So they a lot of times have been called incidentalomas to describe them. And secondly, the CT has gained widespread acceptance as a technique of choice for differentiating adrenal adenomas, which are benign adrenal masses, from metastasis. The characterization of adrenal masses is accomplished by assessing their attenuation values and by evaluating the degree of IV contrast that washes out of the mass on delayed imaging. And because accurate characterization often requires an adjustment in the scan protocol, the CT tech should be familiar with that current information, because an astute technologist can save a patient time, money, and the radiation exposure of repeat examinations by identifying those incidentalomas and tailoring the study to provide the radiologist with the data necessary to characterize it as a mass or benign. As a benign or malignant mass. Romans goes into a pretty good discussion about adrenal gland disorders and all of that, but we're going to save that for the pathology class. So looking at slide 92 here, the adrenal glands are located, they're superior to the kidney, and they can have these inverted shapes here. They can be an inverted Y or a V shape, or a T shape, which is about like this. Or you can have this triangular shape here, which is similar to the inverted Y. Or they can be just this little straight sliver here as well. So when you're looking at an axial slice of the adrenal glands, they're going to be lying on top of the kidney, and they'll look like one of these four configurations here. We'll look at them on the scan in just a second. So they have a 25 to 40 Hounsfield unit enhancement, which is similar to muscle. Thinner slices, 3 to 5 millimeters, are usually used to display them, but you can use 0.5 to 2 for specific assessments. Usually those are rebuilt. The indications for scanning adrenal glands is to rule out an adrenal mass. Most are benign adenomas. And on non-contrast studies, adrenal masses less than 10 Hounsfield units are benign because they're containing a cyst or something. Fluid, because there's like a cyst. Metastatic lesions remain enhanced longer than the adenomas. So that's another cue for knowing that these are benign or malignant. And then they're scanned for oncologic staging. And adrenals are a common site for lung metastasis because they're located right there by the diaphragm. So on a CT axial slice, here's a diagram of this image here. You have the left kidney, and then the adrenal gland kind of sits right up here on top of it, but in between there's fat. And so what you're looking at, the reason why it doesn't, it's not connected right here to the kidney is because of this area of perirenal fat that is on top of the kidney that separates the adrenal gland from the actual kidney parenchyma. So, crust of the diaphragm kind of comes here around, and here's the vertebrae. The aorta is right here, and then the splenic vein and the pancreas are right here. So this is your adrenal gland is going to lie right in that area here. So if you look on the CT scan, you see there it is, the tissue that's that inverted Y, inverted V shape, or the triangular shape of that left adrenal gland here if you follow my cursor. And then here's the perirenal fat that's separating it from the actual parenchyma of the kidney. Here's the crust of the diaphragm, it's kind of running right through here like this, and aorta, of course, and then the left kidney. Pancreas is coming through here like that. So here's another image. These are we're going to begin here with the anatomy that we've covered so far. We're going to look at it on axial slices. So we have the spleen located here, of course, and the splenic vein is here, and it's vein because it's not bright white, highlighted, enhanced as an artery would be. Here is the right adrenal gland coming in right here, this little area, and it's got a different shape than all of it, but once on different slices you can see how it's starting to form, whether it's going to be one of those four configurations. Crust of the diaphragm here and here. Probably going to be at top of an adrenal gland here too as well on the right side, left side. This is contrast. It could be in the stomach. And this may be gastroview or barium, but you can see how bright it is and how it can streak across the pancreas, and different concentrations inside the stomach cause it to do that, and we can get artifact across the pancreas and not see it. So here's again the stomach. Here's the falciform ligament that attaches to the anterior wall of the abdomen, kind of separates the liver into the lobes here, and there's the liver, of course. The right adrenal gland coming in right here. It's going to be a V-shaped one here. Splenic artery coming this way through the spleen. The body of, to the spleen. Body of the pancreas kind of runs right below that, and we'll catch more of the pancreas on the next slice. And here it comes, pancreatic tail, pancreas coming through this way, splenic vein coming through there, spleen over here. Here's the splenic artery coming off the aorta. IVC, inferior vena cava, the portal vein. So you need to be able to recognize the difference between the portal vein and the IVC. They're about the same shape in some patients and same size. Portal vein is going to be over here supplying the liver. So you need to be able to distinguish between those two. Portal vein is probably going to have more contrast in it than the IVC at this point. And you can see the aorta is not very highlighted as well. This is late phase, and these are veins, portal venous system supplying the parenchyma of the liver. Here's a coronal slice. You're going to be turning in coronals probably with every CT abdomen that you do, so you need to know the anatomy in the coronal plane as well. So here we go. Hepatic veins up here, the left portal vein coming off, and the right portal vein, and then here's the main portal vein. Little dark area is the gallbladder. Here's the head of the pancreas. It's kind of busy down in there to distinguish it, but if you follow it back, here's the tail, the body, and then the tail is going to be behind it. We don't have it on this slice. Here's the stomach, fundus. It's dark, full of air, no contrast. Could be there's nothing. Water, I guess, maybe, but I don't think there's anything. Here's the spleen, superior mesenteric vein comes down and forms the portal. Mesenteric artery is below it, superior mesenteric artery coming off of it. The aorta is back here. That actually could be the IVC. You just have to see it on another slice to figure that out, whether that's the vein or the artery. And this slice is taken, it's through this midsection here. So we're going from coronals from front to back or back to front, but we're going in this direction. And this slice is it's not exactly mid-axillary, it's more anterior in location. So here's a axial slice through the kidneys and the liver. Gallbladder is showing up here below the liver. The duodenum is full with contrast right here. It's going to be in this location. Here's the pancreas, the body. It's going down. These are loops of bowel. Jejunum probably. Left adrenal glands coming in, little sliver there. Superior mesenteric artery is a very important artery in CTAs that we'll talk about later, but it supplies the mesentery. It can have stenosis and atherosclerotic disease in it, and the patient can suffer from dead bowel because of that. So superior mesenteric artery is a good one to have patent, so we'll be looking at that with CTAs. Again, here's the IVC and the portal vein, so you need to know the difference between those two, where they lie. IVC is more posterior. And the dark area that you see on the scans, this is going to be fat, all right? Perirenal fat surrounding the artery, fat here within the mesentery. A lot of times if you'll see vessels and strings streaking through there, you're still looking at fat around the mesentery, because the fat's going to be dark, just like out here, right? And air, of course, is going to be dark. Just a review. Again, there's another slice, coronal slice. This one's going posteriorly through the kidneys, right in behind the aorta, which you see right here, and the spine's coming in. Here's the right kidney that's a posterior pole that we're catching. Anterior pole of that right kidney. Whoops. Anterior pole of the right kidney, right here, sorry. The aorta, stomach, IVC here, really big. Portal veins behind it. Here's the right hepatic vein coming off the portal vein. Here's the ascending colon coming in on the right. The GE junction, where the esophagus is coming into the stomach, and then of course there's the stomach. We have the spleen and the tail of the pancreas here, which is lying in this direction. And here's descending colon. And one more thing here, there's psoas muscles coming in. We'll talk about those later, but just so you know, here's psoas muscles, iliac crest here and here. Lungs, of course. This one is a nice image of the inverted adrenal gland on the left, inverted Y. Just wanted to bring that in to show you. It's a good picture. Now look, if you can think about this for a second, this is going to be which phase? If you said arterial, then you're correct. So here's a arterial, the aorta is really highlighted, and you got these splenic artery, it's highlighted coming out mesenteric. So this is a really early phase, probably for aorta or CTA study, the arterial phase of the artery. But it showed the inverted Y shape of that adrenal gland really nicely here. All right, so that concludes our anatomy thus far with pancreas, adrenals, and spleen. Next, we'll be talking about the genitourinary system, and then we'll go into the bowel and everything. So we'll talk to you next time.